Hello and welcome to this edition of GIE Author Interview Series. I'm Rohit Goyal, a PGY3 internal medicine resident at LSU Health Shreveport and an incoming GI fellow at Mayo Clinic, Arizona.
And I'm Nikita Garg, a PGY3 internal medicine resident at Geisinger and an incoming gastroenterology fellow at University of Missouri, Kansas City. We would like to thank the GIE editorial board and reviewers for their valuable feedback on our upcoming paper in GI endoscopy, which is referral patterns and outcomes in Barrett's esophagus patients at an expert endoscopic therapy center, impact of radiofrequency ablation prior to referral. And on behalf of our co-authors, Dr. Ayer, Dr. Leggett, and Dr. Kodipilli, we would like to walk through this paper.
So, Nikita, let's start with what was the motivation behind the study.
That's a great place to start. So, over the years, we have noticed more and more patients being referred to our center after receiving RFA prior to the referral. And with this project, we wanted to see if there is an actual upward trend for this. Additionally, we wanted to see if there are any differences in management and Barrett's related outcomes for these patients in comparison to those who were referred de novo, that is, without any prior treatment.
Exactly. There's almost no data comparing these two groups, so we felt that this was an important gap to be filled.
So, Rohit, do you want to discuss how we designed this study?
Yes, we use a prospectively maintained database at Mayo Clinic, Rochester, which has data on demographics, disease characteristics, management, and outcomes for patients treated for Barrett's esophagus at our center for over 20 years now. We divided all the patients into two groups. Group 1 included patients who had received RFA at an outside facility prior to the referral, and Group 2 included patients who were referred de novo, that is, no prior RFA treatment. We then compared baseline characteristics, treatment these patients received both prior to referral and at our center, and of course, Barrett's related outcomes, including complete remission of dysplasia and complete remission of intestinal metaplasia.
Moving on to the results. So, our cohort included total 794 patients who were treated for Barrett's esophagus at our center. Of these, 58 had undergone RFA before being referred to us, and the remaining 736 presented de novo. When we analyzed referral patterns using univariate logistic model, we identified a clear and statistically significant upward trend. Each year, the odds of a patient being referred after having prior RFA increased by roughly 24%.
So what we had observed wasn't random, and there is a real and steady rise in patients receiving initial therapy outside expert centers before ultimately landing at one.
So overall, using a univariate Cox proportional hazard model, patients who were referred de novo had almost 50% higher chances of achieving complete remission of both dysplasia and intestinal metaplasia. However, after we adjusted for important baseline characteristics, there was no significant difference in the outcomes for patients in these two groups.
Right, and that's the most important takeaway. After receiving treatment at an expert center, overall outcomes among patients with Barrett's did not depend on whether they received endoscopic therapy prior to referral or not.
The next question that arises is whether there was a difference between the treatment given to patients in these two groups.
Yes, we looked into the details of both optimization of acid reflux as well as endoscopic therapy for patients in both the groups. Optimization of acid reflux is an important component of endoscopic eradication therapy for patients with Barrett's, and among the 58 patients in our study who had received RFA prior to referral, around 65% patients required changes to their PPI regimen, and around 45% patients needed addition of bedtime histamine receptor antagonist therapy for their nighttime regurgitation symptoms, despite being on twice-a-day PPI therapy. 8 patients out of these 58 patients continued to have reflux symptoms despite being on maximal PPI and histamine receptor antagonist therapy. These 8 patients underwent ambulatory pH testing with a 24-hour pH impedance study, with 7 of these 8 patients receiving normal results. A total of 6 patients were evaluated by surgeons for consideration of fundoplication. 4 of these 6 patients were referred for persistent reflux symptoms, and 2 were referred for persistent esophagitis on endoscopy. Among the 58 patients, one patient underwent fundoplication, and one patient underwent esophagectomy for their persistent dysplastic Barrett's.
So we know that persistent acid reflux can impede squamous reepithelialization following tissue necrosis induced by radiofrequency ablation. The fact that a significant proportion of patients with RFA prior to referral required medical optimization of acid reflux, that highlights the need for effective reflux control prior to Barrett's ablative therapy to achieve successful eradication.
Yes, and for the endoscopic therapy, patients who had a visible lesion first underwent endoscopic resection with either EMR or ESD, with a decision among these modalities based on the anticipated size of resection. Ablative therapy with RFA was initiated in patients who had no visible lesions on endoscopic exam. Patients who had a suboptimal response to RFA then underwent ablation with cryoablation. In our study, we did not see any significant differences in the two groups for the proportion of patients undergoing endoscopic resection for visible lesions, as well as for the mean number of RFA treatments required prior to achieving CRIM, with patients in group 1, that is, those who had RFA prior to referral, around 80% of these patients requiring endoscopic resection, and the mean number of RFA sessions of 2.86 prior to achieving CRIM. However, the proportion of patients requiring cryoablation for suboptimal response to RFA was almost 3 times higher in those who had received RFA prior to referral.
An interesting observation. So not only there were no differences for outcomes after treatment at our center, but there were also no significant differences in endoscopic resection and radiofrequency ablation.
Another interesting observation that we made was that among these 58 patients who had received RFA prior to referral, only 20% of these patients had undergone endoscopic resection at an outside facility before being referred to a center. However, after referral, almost 80% of these patients underwent endoscopic resection, which was roughly similar to the proportion of patients requiring resection in the de novo group.
Interesting. What could be the possible reasons for this?
Well, this could be explained by either a lower rate of detection of visible lesions in the community setting, possibly attributed to less frequent encounters with patients with advanced disease, or simply due to unavailability of endoscopic resection. Regardless of the underlying cause, it is very important to accurately identify and resect these visible lesions before initiating ablative therapy, because while ablative therapy is highly effective for dysplastic Barrett's, it is limited in its effect to lamina propria, and visible lesions, which may be harboring early carcinoma, might extend beyond this layer. So it's very important to resect all the visible lesions before starting any ablative therapy.
Summarize, we observed a substantial uptrend in the proportion of patients being referred to our center after receiving endoscopic therapy prior to referral. Although there were no differences in outcomes in these two groups, there were some key highlights for the management of these patients at our center. Most of the patients who received RFA prior to referral required optimization of their acid reflux management at our center. Lower endoscopic resection rates prior to referral to our center due to possibly missing out of visible lesions at non-expert Barrett's esophagus centers. And there was a higher need for alternative therapies, including cryoablation.
This was a meaningful project for both of us, and we hope that this study helps guide referral practices and patient management in Barrett's esophagus.
Thank you for watching this video.